Hello, my name is Dr. Joseph Coyne, and I'm presenting to you the master class on formulating financial decision strategies in the changing healthcare landscape. So that you will see on the screen before you a slide describing what are the objectives for us in terms of looking at this as a topic. So, industry financial conditions and the question of who is going to manage, as well as the way in which that managers are compensated today, followed by hospital physician alignment and the role of finance in all of this. Finally, talking about the Triple Aim program as a key program for the value-based purchasing implementation worldwide. So I want to share with you a survey that was done by the American College of Healthcare Executives, and their topic was one of identifying the key challenges facing hospital administrators today, and looking at a survey of 1,000 hospital CEOs and coming back with 388 of them responding, or 36%, with the number one item identified for top concern of CEOs is financial challenges. And this has been the number one concern over the last 3 years. Financial challenges are a very big item for health administration today, and not just in the US, but worldwide, as we look at so many new programs that are focused on trying to manage financially. And so health reform implementation is listed second, followed by the government mandates. And finally, we go down the list and we see patient safety and care for the uninsured, followed by patient satisfaction, a very key area. And physician-hospital relations are something that has become more and more important over time, as well as population health management. So that there are a lot of new changes that are occurring, and probably best represented by looking at the population health management area. So the financial challenges, when looking underneath that, the government funding cuts are number one underneath what is considered the financial challenge. By that, what we're referring to is, for public funding sources, what is going to be the adequacy of these payments and the timeliness of these payments. So this is something which has been a very key concern for hospital leadership around the world. As well as looking at, no longer do we see inpatient volume at same levels as in the past, but going to much, much lower volumes. And that's because of the shift to outpatient care. So we're looking at increasing costs as one of the underlying concerns of hospital administrators. And with that, we're looking at ways to be able to manage those costs and achieve greater efficiencies. And so that's something which has represented itself in a lot of hospitals, with the following chart that shows you the lines of the expenses and the revenues. And too often what we're seeing is that the projections are not good. In other words, the projections that we're seeing today are showing that the revenues are not keeping pace with expenses. In other words, that the expenses are exceeding revenues, as you see in this particular year 4 and 5, even year 3 kind of trend line. So the rating services such as Fitch have given negative outlooks to nonprofit hospitals because of operating margins being strained. So that performance will very much depend on, as noted here in this last bullet point, reducing costs and managing staffing expenses. Moody's has come out with a similar kind of statement of a negative outlook for hospitals, because revenue growth is not keeping pace or not covering the expenses. So S&P, Standard & Poor's, has also made a major concern about their outlook for hospitals, in saying that we have to look at ways to be able to address this. So all of these have come down to the issue of health reform implementation. And we're seeing that as the different governments, ministries of health are going about implementing health reforms, we're seeing that reducing operating costs is a major area, a major priority area, and looking at ways that physicians and clinical providers can align themselves with the payer incentives. Because thinking about this, there's no other bigger area of importance than for hospitals and or providers in general to be able to connect with the physicians and align themselves. So what you see here, aligning with physicians more closely, is a very key item. And shifting to value-based purchasing is what's prompting all of this. So that this is something which is causing for major shifts, major changes, and developing information systems is a crucial element to all of this. So by that, what we're meaning is electronic health records, electronic financial reporting systems. And all of that is going to help us with the item listed next on avoiding readmissions to avoid penalties. We will have a case study to look at avoiding penalties and how important that is because of the impact that that can have on our bottom line. So that this is something that's very important. While we have seen the uninsured falling in the US and other places around the world, the problem that we have seen is that too often is that the increased volume is coming from sources of government insured that will not cover cost. So that's something which is causing us to look at transformational kinds of management so that we're understanding, having a better understanding of risk. Shifts in risk and shifts in investments are something that are causing for hospitals around the globe to be looking at how can they manage this. And I point to the last point here on this particular slide of importance is looking at the triple aim. How can we provide population health, improve patient experience, and looking at reduced cost of care on a per capita basis? That is the triple aim. That is the solution for the future. And Dr. Donald Berwick is the author of that program that has been so successful, initiated by the government in a lot of countries around the globe, and is so important. So this is what we really mean by the topic of value-based purchasing and what we mean in terms of where we're going for the future. It's transformational management under conditions of health reform. So we are in the year 2014, and we are just getting to the point of trying to understand how that quality is affecting everything, how that quality is such a priority area. So we have to look at that as being number one. It's not quantity, it is quality. And what we have to think about is being accountable for everything we do in terms of delivery of healthcare. So that this chart is showing how that value-based payment strategies are the direction that we are moving in. And with the overall aim of providing coordinated care, coordinated systems of care. So it's the right care at the right place at the right time at the right cost, optimizing the patient's convenience, providing the chronic disease management that's so important, in looking at all of this in terms of what we would call accountable care readiness. That's really what everyone is expecting of all the providers, hospitals, physicians, and patients as well. So think about that. We have to have patients discharged from the hospital and follow the directions for them in terms of their aftercare so that they're avoiding readmissions. So what we've heard from a number of places, including Dr. Barry Bittman, is the importance of working towards the triple aim, which is not completely relying on the federal mandates, but looking at ways to be able to integrate into our organizations the value-based purchasing philosophy of adding value and delivering high-quality care. So that is all something which is going to be very important. The question of who is going to manage is a very key question that we have to ask. This is something which is going to be a blend of getting physicians more engaged in decision making. Managers are going to be compensated in a number of different ways, and ones that will include both the medical side as well as the managerial side. So that's something which is going to be a very crucial element. And from a survey that was done on physicians and their leadership, this is something where we've seen that they are actively involved in decision making on a increasing proportion of the decisions that are occurring in the healthcare setting. And that's very important for looking at any kind of changes and trends that are occurring. I covered the issue of compensation in terms of how that we are going about this change, and where that now we're seeing that the CFO today is working not just on looking at cost reductions and efficiencies or financial concerns, but also about clinical quality improvement, also about patient satisfaction. So ask yourselves, what is the percent time that my CFO in my organization is spending on financial concerns as compared with clinical concerns, as compared with patient satisfaction? That's something that's very important. And so thinking about that, it's very easy to see physician engagement is a very key element to all of this. So that's something which we are wanting to look at and to manage in the future. And all along the way, we have to think about physician burnout, as we don't want physicians to be led down the path of overconsumption of their resources. And so we have to look at all the elements to that and try to do what Cleveland Clinic has done in appealing to physicians' core values of looking at what is it they really want to do, and that is practice medicine, practice high-quality medicine. And looking at that as a primary goal is a very important undertaking for all of us. There's a leader from the Cleveland Clinic that has given a very good presentation on this. I recommend that all of you look at that from the YouTube presentations, because it tells us a lot about how that the physicians will be compensated in the future. Managers will be compensated with all elements of the spectrum, including patient satisfaction, clinical outcomes, employee satisfaction, and physician satisfaction. These are all very important elements for managers' compensation in the future. Again, in summary on this, the key elements that we have to understand are the elements of the changes from the quantity to the quality of care that we're seeing today. So that's what we want everyone to be thinking about as we go forward. I would like to shift to the next topic that is on our agenda here, and that is one on looking at the financial statements. So I point out to you that financial statement analysis is a big part of our work, and we have a case study that looks at that, so that we can look at a PowerPoint slide on financial statements and let you all see that the financial statements are something that we will all be looking at on an ongoing basis. And financial reports of all different kinds, so that we have different models for doing so. But the key element to all of this is shifting from the quantity emphasis to the quality emphasis, so that we can use a number of data sources for doing this and accomplishing this. But what's important is to understand how that we have to look at the population we are serving. So population health means that we have to look at data that we can collect on our population and their needs. And so that we have to be looking at all of the sources for data, including the ones you see listed for U.S. hospitals here. And they include the Center for Medicare and Medicaid, which is CMS, and for medical group associations, the Healthcare Financial Management Associations, and state hospital associations. So all that is something that's very important for us in quality of care. So when we analyze financial statements, we want to be looking at all three of the financial statements, but also we want to look at operating indicators that help us understand what is the utilization of our facilities. What is driving that utilization? What is going to be the next need of the population we serve? And all of this is really getting us to value-based purchasing analysis and focusing on assessing quality of care and not just looking at quantity of care. So financial statements are going to be something which we want everybody to understand and to see that. And so the three financial statements that we all will be analyzing are ones that are listed here of the balance sheet, income statement, statement of cash flows. But in addition to all of that, we will have financial statements that we must look at that are going to be developing KPI, developing key performance indicators, developing dashboards that we can assess how we're doing using ratio analysis to compare financial results and quality of care results with expected results. So that all of these things are what we need to be able to do. So that in essence, for you to try as a technique to understand is looking at the short term as well as the long term, looking at profitability that's focused on the short term and solvency that's focused on the long term, so that short term and long term checks are what we really need to do. And for that purpose, what's very important is time series analysis. Time series analysis tells us how we're doing on what we call a year-over-year basis or annual basis, trending out over time. Are we going up in terms of revenues or are we going down? Are we going up with expenses or are we going down? Are we going up with profitability or are we going down? All those things are something that we need to look at, and across a wide range of financial characteristics and categories, including profitability, the ability to generate sufficient profits, liquidity, debt management, asset management are all things that we need to look at. So that with this, I would like you to understand that we need to be always looking at these kinds of reports and financial data. And so that in closing this section on the financial statements and the financial analysis of them, I would like to just refer to the slide here that has to do with our volume indicators. Because volume indicators are something that accompanies our financial data, and so that we always want to be looking at what are the costs for those patients that we're serving. So cost per day, cost per stay. And we can always adjust those costs to consider both outpatient and inpatient. And we have a formula here that you can use to get to an adjusted patient day. So ideally, what you would be able to do is to say, what is my cost per adjusted discharge? That's a good example of the fee-for-service term that we will be wanting to look at, a cost per unit. So having the ability to look at costs is very important. And having a database that's allowing us to benchmark, comparing with other entities that are like types of organizations, is something very important. So here's an example of that we could look at in comparing different organizations and using quartiles to do so. In this case, just looking at the total margin. Dashboards are a key instrument for all of this. Dashboards that tell us how we're doing compared to the competition, how we're doing compared to the national benchmarks. Limitations do exist, and that is something which we all have to take into account and be mindful of as we look at any one of these financial statements. So that's a brief summary on what the financial statement analysis is all about and ones that we look at in this course. So in addition to that, we will have a chance to talk about a hospital setting that is one that really gives us a good understanding of how that we are going to be moving towards a value-based purchasing environment. So when we look at this particular case study, it's called the Affordable Care Act. It could be any name in terms of health reforms, but Mason County Hospital is a real-life example, not by that name, but an example of how value-based purchasing can work or perhaps not work. And so what we've done is looked at data for this organization that you see right here, and it's a population of 177,000 with the number of patients admitted here of 4,986. and serving a population of government patients that are 26% Medicare, and Medicaid is at 17%. So private insurance is a big bulk of their business, 54%, and that's a very good thing in terms of being able to sustain the government-sponsored patients. So in this case study, what we do is we look at some scenarios. So as we move in the direction of value-based purchasing, what's important for everybody to understand is how that we will see that the value-based purchasing program is going to be implemented for a specific population, typically government population. And in the particular case of the US, just for the Medicare population. So that what we do in this exercise is apply the percent of Medicare patients, which is noted above as being 26%. We apply that to the inpatient revenue. And we look at this in terms of revenue from inpatient at 32 million, multiplied by 26% Medicare. And that will be then adjusted by 5 different scenarios where we are assuming that in looking at this particular case, that in each of 5 scenarios, that there's a different level of either subtraction or addition to the revenue for Medicare inpatient population. So that we need to understand this in terms of looking at a range. So what's important to also think about today is that we have to look at more scenarios. We have to consider a range of scenarios. So looking at minus 10% up to positive 10% and little intermediate steps along the way. So scenario 1, minus 10%, is meaning that we will need to adjust the revenue from Medicare. So this 26% is multiplied from Medicare percentage times the 32 billion, and then times whatever is the subtraction or addition. In the case of scenario 1, it's a minus 10%, meaning we have been penalized for poor patient satisfaction by that amount. So therefore, there will be a reduction in that amount of 10%. In scenario 2, it's a minus 5%. In scenario 3, it's a minus 3%. In scenario 4, it's a plus 2%. In scenario 5 is a positive 10%. So when asking where do we come up with these kinds of percentages, these percentages are derived from what's happening today in the real world. And so that in different ministries of health, we're seeing that the range of penalties and the range of bonuses can be anywhere in this kind of range. So we assume a static condition as far as the other sources of revenue and the expenses, and we just look at the operating income, so that what we're doing is calculating or taking into account these steps to calculate what's the percent change, either positive or negative, in terms of our future income, our future operating income. Operating income, of course, is looking at the total revenues minus total expenses for just the operations, not considering fundraising and non-operating kinds of activities. So that in looking at this particular set of scenarios, we are doing so with a spreadsheet. And that's just looking at the income statement here. And so we have built that spreadsheet to show in Exhibit A range of going from, as we just said, from the scenario 1 to scenario 5. So we are assuming that revenues are going to stay the same except for that one item of Medicare penalties or bonuses. And so that we will see what the impact then is after taking into account the expenses for that one key line item, and that is for operating income right here. So the operating income in 2014 was $3,732,200. And so that's going to change for the future when we apply these percentages. So that in our solutions to this, we will be calculating what the net result is. So we have done so already, and much like a cookbook situation, we have the key for the results of this in Excel, and so that we can see what the results look like for each one of these 5 scenarios. So if you have a look at this in terms of the 5 scenarios, we've done the calculations down here. We've shown what the new net patient revenues are. And for each of the 5 scenarios, we see what the impact is on the operating income. That is, what is the percent change from 2014 to the forecasted level for 2016. So notice what these results look like. For the beginning scenario of a negative 10% reduction in Medicare alone for that 26%, which again is 8.4 million out of the 32.2 million, we're seeing that the impact on the operating income, that key line item, is 22% reduction. So think about that. When there's a 10% penalty on just 26% of your population, you can see a 22% reduction in operating income. That's a critical finding. Likewise, in your other end of the spectrum over on the right, so that we can look at, for scenario 5, a positive 22% that is shown here. So that scenario 5, where we see a bonus of 10%, the percent change in the operating income goes up by 22%. So we've covered both points in the percent change analysis here. A reduction of 22% in the operating income for scenario 1 to as much as a gain of 22% in the scenario 5. Notice what's happening with scenario 2, 3, and 4. In scenario 2, where we had a 5% reduction, that resulted in an operating income loss of 11%, followed by scenario 3, where we had a 3% reduction. It was translated into a 7% reduction for operating income. And then for scenario 4, we had for a 2% gain, there was a 4% increase in the operating income. So notice what this says to you as administrators is that look at these percent changes in all 5 scenarios, and you have almost double the impact, almost exactly double the impact of the operating income. Something that's very critical to understand as we go about the value-based purchasing, because value-based purchasing is where we're headed, and that's exactly what we need to be aware of as we go forward in our analysis. So I'm going to close with a discussion of the pay-for-performance reforms and how that we're moving in this direction. So the closing comments that I'd like to make are that we have to pay attention to all of these changes as managers as we look forward. So hospital and physician reimbursement is going to change worldwide. The World Health Organization has told us that. Margaret Chen, the leader, has told us that. We've seen the implementation in so many directions of the Triple Aim program. So reduced payments for higher levels of hospital-acquired conditions is going to require us to look at a whole new environment. The new environment is now centered on Healthcare Reform Act requirements. And value-based purchasing means that we're looking at clinical outcomes. We're looking at bundling of payments so that no longer will it be a fee-for-service environment. Slowly, in certain countries and certain organizations, we will see this change occur. It won't happen rapidly, nor will your systems be able to prepare for that rapidly. It will take time. It will take time to get to a stage of saying, yes, I can do population management. Yes, I can do value-based purchasing. Yes, I can manage my population. So accountable care organizations are a step along the way and translated into a lot of different terminology. But basically, they consist of networks of hospitals, physicians, managed care organizations, and I do mean that. We are going to see the merger of providers and payers, providers and insurance companies. And you say, how is that possible? It is already happening. It is happening in the US. It is happening elsewhere, that we are seeing providers working with payers because government programs are in place that are allowing for these organizations to work together and to be able to generate savings by doing so. Savings in the form of care improvement. So care improvement, as you see on this slide, is looking at how participating providers can be able to share in the savings. So that's something which is going to require a great transition, and is going to require us to use more sophisticated operational analytics to identify all the opportunities, assess the networks, as in what are the physicians that we have in our network to be able to provide care to our population, and perform the integrated analysis necessary for us to move along in this direction. So it's not just going to be enough to look at management tools or financial management tools to reduce the variation that's required for serving our populations. We have to have care management tools that are ensuring integration of care, integration and coordination of care, and with logic tools being all a part of that. So that we have to have the flexibility built into all of this process for improvement, and we have to look at ways to be able to do that. So far, the experience that is documented in the journal called Health Affairs has shown that we're very slow on implementing this whole process in terms of the bundled payment, as we call it, meaning a global payment for a whole population in terms of specific areas. So from this experience where that there were 6 hospitals out of 8, six of California's largest health plans working with 8 hospitals on orthopedic surgeries, and that is for total knee and total hip replacement, that we found that it was a problem with the participation level. A problem because there was a great deal, as you see on this slide, of failure to participate, a failure to see the benefits of participation, and really a lack of preparedness. And so that big discussion on all of this is the issue of risk and reward. How can you manage your risk? How can you manage your population so that you can achieve a reward? So while there does remain this kind of a future in terms of looking at things like value-based purchasing for our future time periods, it's going to mean that we're needing to achieve patient satisfaction levels that allow us to be able to receive a bonus. And also for us to be managing readmissions. We cannot have patients leave the hospital and not understand what to do in the way of following medications, compliance with medications after leaving the hospital. And all this is important for reducing hospital-acquired conditions and being able to achieve our results. So in conclusion, I'd like to say that this review of payment reforms is highlighting some of the key developments in healthcare financial management. It's no longer financial management by itself. It's no longer simple solutions. It is looking at problems that are spanning a lot of different disciplines. And so the metrics, the culture, and the strategies are rapidly and continually changing. I've enjoyed this presentation with you, and I hope that you have found that this has been beneficial to you in your management task. We will go forward from here to look at all the various ways of implementing the reforms and looking at our programs for doing so. Thank you very much.